Diego Borquez and Roger Little over at GI here, just about the time I arrived a couple years ago, had done this beautiful study where they would stain GLP-1 cells and then stain neurofibers in the gut and show that they seem to abut each other. It's shown really nicely in this picture here. So here's the schematic, a GLP-1 cell with these neurons just attaching, almost like synapses in the gut, which is actually pretty interesting. This is exactly how taste buds in your tongue are wired, right? So this would be the sensory part of your taste bud. There's an inner neuron here, and then it goes to the brain. And it turns out if you follow the gut down, this same wiring pertains. And so one hypothesis that's been kicked around a lot is that GLP-1 is secreted into the substance of the gut. It activates these afferent neurons, and then there's a reflex arc to places like the islet and the stomach where GLP-1 does its business. This also helps explain why GLP-1 seems to cause satiety, because you give somebody enough GLP-1, they will eat a smaller meal. If you give them too much, they will get quite green around the gills. So that all of the GLP-1 effects are neatly explained by this beautiful hypothesis here, which has been, 2007, really, really hard to prove. This is a very tough system to take apart. You can't take out the gut and say, well, now we've, because there's too many confounders there. We have approached this in a couple of ways. You can't get peptides across the gut. They simply aren't absorbed in their full form. And if you put them in the stomach, they're digested. So what we took to doing is seeing if we could make them lipid soluble and get across the gut. And so there's this short chain fatty acid that you can bathe your peptide in, and it makes it lipid soluble. And you can use that to try and get it across the gut. And there's a lot of drug development in the area of giving peptides through the gut. Most patients say, I'd much rather take my insulin as a pill, or I'd much rather take whatever peptide I'm getting. So a lot of people look at this. We got some snacks so we could do some experiments. The other thing we did, we found this cool paper where you can stick biotin, which is vitamin B6, I think, onto your peptide. You can covalently bind them. And then there's a multivitamin transporter that will grab the biotin and take it in, and it will drag your GLP-1 in with you. So we did both of these things and did studies in some animals. And you can see here, this is plasma GLP-1 when we gave them saline. This is when we give them just GLP, the peptide, right into the stomach. But if you coat it with snack, all of a sudden you can drive the plasma levels really high. And we could do the same thing with our biotin trick. So now we can get GLP-1 right across the gut. And so theoretically, that ought to be able to tickle those neurons and give us some activity. And what do we see here? This is normal glucose in a mouse, and then this is a mouse given an injection of GLP-1, and then this is given the oral form with this snack, and it seems to work pretty well. And then here's the biotin, there's the control, here's an injection, and then here's the biotin labeled. So it seems like we can push GLP-1 across the gut and get some effects. Now we have to finish these studies and show that these are specific to the gut, the action. But to my way of thinking, this is the most direct way that anybody's tested this hypothesis, which, again, for the folks in the GLP-1 field, is the favored hypothesis. So what's another alternative to endocrine function? Would be paracrine function, right? So paracrine action is products from one cell dropped into its local neighborhood that affects another cell, right? So I told you that proglucagon is made in the islet, where the beta cells are, by alpha cells that make glucagon. And again, the party line is alpha cells only make glucagon and not GLP-1. And of course, that's not true because things are never that simple. Alpha cells can process proglucagon to GLP-1. Cultured islets can secrete GLP-1. And the proportion of glucagon and proglucagon that comes out tends to be regulated. And this is a little demonstration. So here's a mouse islet. These green cells are all beta cells stained for insulin. These red cells on the edge are stained for GLP-1. If you put these cells in culture and measure, you can measure that they secrete glucagon, but they also secrete GLP-1. But better yet, you can get islets out of humans, which they isolate for transplants and things, and they will secrete some glucagon and some GLP-1. I was thinking the ratio would be like 10,000 to 1. It's more like 10 to 1. So it's not a trivial amount of GLP-1. And moreover, when you make the glucose in the media go up, the glucagon goes down and the GLP-1 goes up. And this effect is even more pronounced in islets from type 2 diabetic patients. So I show you this just to raise the possibility, make plausible, that GLP-1 may be doing its business right there in the islet. So that when we give somebody a DPP-4 inhibitor and protect GLP-1 from being degraded and say, oh, looky here, that's great, the insulin secretion's better. The circulating GLP-1, in my view, doesn't have anything to do with it. I think what we're doing is protecting GLP-1 in its neighborhood, in the islet here, or in the neighborhood of the gut, where it would also be degraded. And I think that's how the system works. Now, we have some ways to go before we show that for sure. So I've told you GLP-1 in a normal setting is not a hormone, or at least I think the evidence is strongly weighted that way. Is it ever act as a hormone? Well, there is one circumstance. When we give these injectable GLP-1 analogs, they certainly work by floating through the blood and hitting target tissues directly. Pretty good evidence for that. And they last a long time. There are now preparations you can give once every week or once every 2 weeks, depending on how the pharmacology has been done. But there's another non-pharmacologic condition, and that is after bariatric surgery. Right? So bariatric surgery is about 500,000 cases a year done. Most of them are either gastric bypass or sleeve gastrectomy. Those are common weight loss surgeries, and they're done a lot because they work really well. And it turns out if you have a gastric bypass or a sleeve gastrectomy, your GLP-1 levels are really, really high. It's unclear exactly why this is, but if you think about it, when a surgeon gives you a gastric bypass, he makes a little tiny pouch, kind of 2 shot glasses of volume, and then he sticks the middle of your intestine right to it. So when you eat, stuff flows right through. So you really flood the gut with nutrients. So that I came across this number the other day and it blew my mind. When we eat a normal meal, whatever you had for lunch, your stomach will carefully meter out carbohydrate to your intestine at somewhere between 2 to 5 calories per minute. Does that metronomically all the time. When you have a gastric bypass, your intestine is faced with 100 calories per minute. So it's a 20-fold excess of nutrient challenge, which does all kind of goofy things, including make you lose weight, but sometimes give you a tummy ache. But it really drives GLP-1 levels. So, of course, we studied this, and we hypothesized that if you had a gastric bypass and we blocked your GLP-1, it would have a big effect on your insulin secretion. That is, all this stuff floating around would really be driving insulin secretion, and we'd be able to see that when we blocked it. And that's just what happened. So here's people after a gastric bypass we gave them Ensure, and they secrete a hell of a lot of insulin. And when we block it, big hole here, we really knock down insulin secretion, sometimes 75%. And then this is the controls with saline and with Extend. And this doesn't look as big as the 30% I showed you before, but that's because it's a really little meal. When you give a person with a gastric bypass Ensure, you just give them a little wee bit. But again, this is the GLP-1 effect in a bypass patient, and this is a control. So people with a bypass have high GLP-1s, and they have big GLP-1 effects. Now, if you're an endocrinologist, your impression is, yeah, bypass is good, but I see a lot of patients sent to me because they have hypoglycemia. And somewhere between probably 1% and 5% of patients that get a gastric bypass, get their plumbing rewired, will get hypoglycemic a year or 2 afterwards. And it can be really bad. I mean, they can go to 30, they can have seizures. And we recruited a group of those, people that were really having bad hypoglycemia, kind of people that were being driven by a spouse or a sister or a friend to our clinic. And you can see here when we gave them Ensure, their blood sugar goes up really fast. Again, it just pours right through you. And then it comes crashing down. And all 11 of these subjects got low blood sugar and had the usual shaky symptoms and stuff. We recruited another 10 who had the same operation about the same time, weighed about the same, and they never had symptoms of hypoglycemia. So we got the 2 extremes of the spectrum, and you can see here when we gave them Ensure, pretty normal, right? Except that they go up high real fast. And the controls are here. These are people that don't have an operation. And you can see how fast the glucose rises by just looking what a normal person does with Ensure, not a lot. Well, so we repeated all these studies with a GLP-1 blocker, just to see, does GLP-1 cause the hypoglycemia? Well, the blocker makes the asymptomatic people and the controls a little bit hyperglycemic, just like I showed you before. You block GLP-1, you get a little bit glucose intolerant. But all these people got better. Nobody was hypoglycemic when we blocked GLP-1. This is just remarkable. Now, unfortunately, the blocker is a small peptide that has to be given by continuous infusion, so it's not like it's available for treatment. And it's sort of an orphan compound, so I've not found anybody that was interested in preparing something that we could use. But again, this kind of study amplifies that in some situations where you secrete a hell of a lot of GLP-1, it may actually be mediating some of the effects. Well, so one of the questions that always comes up is, oh, do the hypoglycemic guys have higher GLP-1 secretion? Does that explain everything? Well, it turns out it doesn't. Here's the controls with just a pittance. You really have to strain to see that they have any rise in their GLP-1. And here's the asymptomatic people, and here's the symptomatic people. And it's about the same. There's no difference. And we must have measured GLP-1 in 50 people who had gastric bypass. And there's no systematic difference in the levels, even though the levels are high in everybody and does a lot of business. So we wondered then, well, maybe there's different sensitivity to GLP-1, right? There are different sensitivities to insulin. Some people are real insulin sensitive, some are real insulin resistant. What about sensitivity to GLP-1? So we did the following study. We raised the blood sugar a little bit with a glucose infusion just to kind of activate the pancreas. And then we gave them a staircase of GLP-1 by IV infusion, starting at really low levels to really high levels. And you can see that this staircase gave us a gradient of infusion. We did this in healthy, lean, and obese people. And you can see that as the staircase of GLP-1 goes up, so does the insulin. The obese more than the lean, because obese people are compensating because they're insulin resistant and secreting more insulin. And this was the beta cell sensitivity to GLP-1. So if we plot insulin secretion versus the GLP infusion rate or the GLP-1 level, we get a nice curve like this. This is a dose-response curve. This curve, the relationship of secretion to GLP, should be the sensitivity to GLP-1. Again, the obese look better than the leans. When you control them for their level of insulin resistance, they fall out on each other. So this is just what you'd expect. What we didn't expect was this. In our population, we got these kind of curves. They all mean down to something like this. But you got some guys that are really sensitive and some guys that are really not. And when you plot their sensitivity, that is this slope, you see that there's about a 10-fold difference just in a healthy, normal glucose tolerant. Hell, these guys had a mean age of 25. But some are real sensitive and some are not to GLP-1. This is cool, really, because it suggests that there may be ways in the future with better biomarkers to say, oh, you'd be a good candidate for a GLP-1 drug, and it's going to be a waste of your money, right, to do this. So this is the kind of thing, we didn't do the study for this reason, but it does speak towards personalized medicine or being able to tailor drug therapy. But it also suggests that it may explain the hypoglycemia in the bypass patients, right? It may be that if you do this same test in the guys with hypoglycemia, they're all up here and the other guys are all down here. So that at a same level of GLP-1, one guy's getting walloped by it and the other guy's not. So let me just summarize what I've told you and tell you a little bit about what we're thinking about doing in the future. So GLP-1 and GIP for that matter are essential for normal glucose tolerance. If you don't have them, you're a little bit glucose intolerant. Now, it doesn't cause diabetes. There's no genetic mutations. It doesn't fall out of a GWAS study. The levels are about the same in diabetics and nons. And diabetic patients respond as well as normal people to GLP-1. They just have crappy beta cells, so they don't respond to anything very well. The physiologic mechanism of action for GLP-1 is unclear. But I would argue that if you're calling this a hormone, you're not accurately representing what's going on in the physiology. Finally, patients with Roux-en-Y have very high levels of GLP-1, and they have increased GLP-1 action. And in some of these people, it may be causing pathology, that is hypoglycemia. And then GLP-1 sensitivity varies widely amongst humans, meaning that there may be better and worse candidates to treat with these drugs. Although I should say, we haven't done this study yet in type 2 diabetics. We plan to. So what's the relevance of this all to clinical medicine? Well, I told you, this has been the IT drug class. I mean, the SGLT2 inhibitors are starting to push GLP-1 a little to the sideline. But these are pretty good drugs, and this is one of the drugs, liraglutide, which is a once-a-day, long-acting GLP-1 agonist. This is a study where it's compared to a shot a day of insulin in poorly controlled patients. These are A1Cs of 9 at the beginning. And both groups get a drop of about 2 percentage points of A1C. Now, if you're an endocrinologist seeing diabetic patients all the time, 2% just doesn't happen, right? Only if your patient sort of gets really sick and loses a lot of weight or decides to start running marathons or something like that. We're usually popping the cork if we get them down 0.5%. But 2%, that's a pretty good drug. Moreover, whereas insulin treatment tends to make you gain a few kilograms, so 91 to 93, these drugs don't make you gain weight, and oftentimes you'll lose a few kilograms. So patients like that. I never advertise these as, oh, you're going to fit into your prom jacket again. But I do say it probably won't make you gain weight. So good drug target. The GLP-1 system is a good, the question is, are we maximizing it, right? I'm talking, we're talking about, these are still diabetic people, even with a bang-up effect. That 7 is still an average blood sugar of 150. And when we started this whole story and would give diabetic patients GLP-1, their blood sugar would go to 92 on average. We would normalize blood sugar with GLP-1. Now, this may just be an experimental phenomenon, but it does speak to me that maybe we're not getting the full, because we don't know exactly how they work, we're not maximizing the system. We are limited because, again, right now you get toxicity and you can only give the dose to a certain amount. People get nauseated, they can't take it. So I think even though this has been a hot area, the development is fairly mature, I think there's still hay to be made in this market. So what are we doing now? Again, I talked about the beta cell sensitivity, how that varies. We're going to test that in Roux-en-Y subjects. Actually, we already did. We're just analyzing the data now. We're going to also do this in diabetic patients because it would be cool to be able to hypothesize that you couldn't in the clinic do the kind of clamp studies we do. But if you prove the principle, then it's reasonable to look for a biomarker, and then you could start to potentially give people drugs they'll respond to. We're going to do some studies to really follow up this fasting GLP-1 effect, which is there over and over again and seems to associate with diabetes. And then we're going to test the hypothesis that GLP-1 compensates as your beta cells start to fail. So we do these studies now over at the Center for Living because we're part of the Stedman Center, and that's a Stedman building, and so the rent is free. And also there's a really talented bunch of clinical investigators that do this kind of work there. So we've plugged in there and are negotiating the Duke IRB seems to be way harder than getting an NIH grant. But we've finally done that, and we're recruiting now for our first sets of studies. And we hope to do a lot of those over there. And in the future, maybe we'll have more to talk about here. So I'm happy to take some questions. Yeah?
When you're talking about GLP-1 compensating for impaired beta cell function, that would include complete loss of beta cells. I mean, let's talk type 1s.
Let me tell you what I mean by that. So most of the data that makes me say that is not our data from humans. I scratched that together going back through our old data sets. I think you can make a case. In a mouse or a rat, if you give them a beta cell toxin and kill 60, 70, 80% of their beta cells, they'll make a lot of their alpha cells that aren't susceptible to that will hypertrophy, and they start to make disproportionate amounts of GLP-1. If you take a rodent and a female rodent, study it when it's pregnant, they get real insulin resistant during the latter part of pregnancy, just like humans, and their beta cells expand, and their GLP-1 levels are high at that point. If you feed an animal a high-fat diet, make it insulin resistant, the alpha cell starts to make. So there's preclinical data that supports this. And again, what's a very interesting model to me is that the alpha cell may funnel pro-glucagon peptides to one side, the glucagon counter-regulation side, or the GLP-1 pro-insulin side, depending on the circumstance. And we actually, this is all our human data. We actually have a couple of mouse models that I think are going to allow us to take that apart. But that's sort of our model, our system that we're taking. Does that get at your question? Yeah. Please?
Question that has been bugging me for a long, long time. It's regarding adipose tissue.
Yeah.
Visceral versus peripheral. How is that playing? Does it play into any of this?
Yeah.
Is there a way to really pull it apart, tease it out,
Yeah.
get it?
So this is something, we just recruited a really hotshot guy from Toronto, a basic biologist, and he doesn't study GLP, he studies the other one, GIP. And GIP, besides the beta cell, the receptors are on the adipocyte. And so he's chasing that story right now. You can make a case that one of the things that GIP does after meals, now that gets secreted like a proper hormone, the levels get really high. And they stimulate insulin secretion, but they also stimulate fat cells to take in. I mean, it's a prandial hormone. It's how you acquire fatty acids into your adipose tissue. His hypothesis is that the receptor is going to be expressed differentially. So the visceral depots may have a lot, and the peripheral may have less. And he has some evidence in that. And again, it's not far-fetched then to start to say, well, maybe people have differential expression, and maybe some people have more and less. And so that's a totally untapped area, and he just ends up being a very clever guy and has a model that's going to allow him to test that. By and large, I don't think of the incretin system, that is the gut hormones regulating insulin, to be having much more of an effect on adipose tissue than that. That is, GLP-1 doesn't do very much on that. When you give a patient a GLP-1 drug and they lose weight, and on average people will lose 4 kilograms, which is nothing to sneeze at unless you weigh 244 kilograms, and then it's not. But what we don't know is whether that's proportionally visceral fat or sub-Q fat, or whether that varies. It's a great question that nobody's addressed. But if you take people and you exercise them, right? You randomize them to the exercise group and you measure body composition before and after. They tend to lose disproportionately visceral fat. It would be very interesting if some of these drugs that affect body weight do the same thing, but that hasn't been looked at yet.
Thank you.
Yep. Good. Thanks.
Thank you.
Unless you had a question, I want to cut you off.
I'll catch you after.
All right.